I work as an obstetrician-gynecologist in metropolitan area in the suburbs. I am married. I have 5 children, and my practice focus, while I see many other things, I try to provide the service for women who are using natural family planning methods or fertility awareness-based methods of family planning to help them in their fertility journey and to give deeper insight and essentially journey with them. Because in my experience as a professional, that's just an area that's often overlooked in mainstream gynecology. So it's been a privilege to do that. No, so you don't really learn much at all in medical school about, I would almost argue anything about natural family planning. At least in the United States, most medical school education will cover 2 months of training in OBGYN in like a clinical sense, where you're actually going in with other with doctors and training behind them. If you select to be an OBGYN or family medicine physician, you'll get more direct training with women's health, but truly OBGYN is are considered the experts in women's health. So we did 4 years of residency in the United States. So after medical school, we do 4 years of training and hands-on OBGYN, basically OJT, on-the-job training for 4 years before we're kind of cut loose into the world to practice on our own. And in my residency, I did not receive a single lecture on natural family planning or cycle management in any way other than, typical contraceptive use or a little bit in infertility rotation, but nothing at all to do with natural family planning. Speak very freely. I had a conversion, a religious experience when I was a resident, and I decided to follow, like so many probably other people are listening. I decided to follow a religious worldview when I decided not to use contraceptives. And actually, even before that, I was coming on board with that. And I'm a Catholic, and there were a bunch of people in my peer group that were Catholic, and they were asking me these questions as an OBGYN, like, well, you must know this. And I didn't know any of those questions. It was very uncomfortable to me. And I was like, wow, this is a much overlooked area of medicine. And I saw such a need for it that I kind of went out on my own and started reading more. And there are communities of doctors who are interested in it and will study, but basically you're on your own to develop that interest with other like-minded physicians and groups. Yes, I have a large percentage actually of women who will travel, I mean, to me, ridiculously far, like 2 hours away, even or out of state, in order for me to just read their charts. And I think the part as a physician that's difficult, and where I encourage my fellow physicians or mid-level providers, nurse practitioners, physician assistants, nurse midwives, is that this is easy to learn. Well, you can learn it. It does not take a long time to have a grasp of it. I would say it does feel difficult to become an expert in any way. I still don't feel like I truly am an expert. There's so many unanswered questions and things that I don't feel confident in. But if you embark upon it, the brass tacks of understanding the fertility window, what the follicular phase is, the luteal phases, biomarkers, it's very approachable, and I think it's easy to learn. You have to understand, if you have providers and they're looking at charts and they have no idea what they're looking at, it is kind of creating a power differential. And I think it makes people feel uncomfortable, right? The physicians are supposed to be the experts. And so if somebody brings something into your office that you've never seen before, you don't see any value in it as a method of family planning, and it's hard to invest your time and resources into learning it for what seems, to many people, the handful of patients that you'll see in a year that use it. Now, I will say, because of the new technology, more doctors are probably seeing it. I see a lot of it in my practice, and I absolutely use the menstrual chart. I look at it every single time. I look for things that these women may be identifying that that they want to share with me, or I'll look at it and I identify things that maybe they haven't picked up on, but I always look at it as a diagnostic tool. Yes. So if I have seen 6 months of charting, you can immediately glean right away. Is this woman ovulating? Is she having normal luteal phases? It may seem like small potatoes, but is she timing intercourse appropriately? Sometimes I look, I'm like, you're trying for pregnancy and they're not in the right spot. Like this is, you're missing this here. Or times of many charts where I see, and like, especially with basal body temperatures, when they're not charted, where I'm like, are you sure this is a period and this isn't just abnormal bleeding event? Cover a lot of that. And if I don't have a woman charting that, then I'm basically left with, okay, it's recall, over the last 6 months, what do you think? And so when I do see regular charts, I'm able to pretty much immediately start diving into different diagnostic processes, especially when it comes into infertility or subfertility. I have women and I'm able to kind of go down a pathway where I'm like, oh, this doesn't look like we have robust ovulation occurring or something like that. I would veer off different pathways rather than just kind of throwing out a blanket approach to every woman who comes in telling me she wants to get pregnant. So it's very helpful in honing in on what your next steps are. All menstruating women and ovulating women should be tracking it. It adds such an incredible amount of information about an extraordinarily complex process that can help us to discover underlying abnormalities. Things like thyroid disorders, other hormones that can be produced by the pituitary gland, adrenal disorders, ovarian tumors, so many things, abnormal findings within the lining of the uterus that you can pick up on menstrual charts. And so I encourage everyone to do it. And I personally take great issue about essentially distilling down the value of ovulation as a standard for reproductive health to whether or not women want to make a baby or not. Menstrual abnormalities, specifically the kinds that we see oftentimes in polycystic ovarian syndrome, PCOS, those have significant implications for that woman's long-term health. We know that women with PCOS have an increased risk of diabetes, endometrial cancer, which is a cancer of the uterus and the lining of the uterus. They have more likely to have lipid disorders, meaning cholesterol abnormalities, weight problems. So those are long-term health issues, and you can discover and uncover some of those by looking at menstrual charting. And I encourage all women, my daughter, young women, teenagers, to go up, embark upon that journey of understanding what their reproductive health looks like in order to identify abnormalities if they were to arise. Yes. So I always follow my charts on women who have done ovulation induction. Specifically, certain methods, the two most common methods for ovulation induction in a basic general practice or OBGYN office would be to use clomiphene citrate, which is Clomid is usually what it's called, and letrozole, which goes by the name brand Femara in the United States. Those two methods actually can have different effects on cervical mucus output. You can notice whether or not these women have better luteal phase temperature shifts and longer luteal phases, which you would ideally see with ovulation induction, specifically in women that have ovulation disorders. So I love to see that because I want to see, did it occur? So when I give women individually like letrozole, I do what most women start on, which is 2.5 milligrams, cycle days 3 through 7. Well, if these women haven't had peak type mucus or they haven't shown any signs of fertility, then they can call me and tell me, hey, listen, this didn't work, versus just waiting for their period to come and, doing ovulation predictor kits. They know that it's not happening. And so I love that because I can actually get the messages before the obviously negative pregnancy test if they didn't ovulate well. So I love that very much. Yeah. No. So it depends on what the condition is that you're trying to treat. So women with polycystic ovarian syndrome oftentimes can have success with ovulation induction with Clomid or Femara. But I have some women with a condition, many women actually, that have what I call hypothalamic hypogonadism. And these women, truly the FSH and LH pulse isn't even really turning on. So these are women whose bodies aren't even trying to ovulate. So I try to describe that as, PCOS, it's signaling, but it's desynchronous. And so you just kind of need to break in there for the most part and override the signal and help it to function appropriately. But then we have some women who aren't even trying to. And so you're trying to kickstart a system that isn't working. And so, unfortunately, some cases are easier to treat than others, but that's why it's important to have these relationships with your physician and also to do charting. I have women who haven't had periods for 8 and 9 months at a time, but they're also chronically dry. So they're not showing mucus patches. They're not showing in any way clinical signs that they're trying to ovulate through the discharge changes you would see with rising estrogen. And when I hear that, or I see that in a clinical experience, I just kind of get ready, like, okay, this is going to be a little bit more of a difficult case to get these women to ovulate. And so if I'm getting cycles with women and I'm like, yeah, you seem to be ovulating, but it's too far apart. You're having your peak day on like cycle day 52 or something like that. And then the luteal phases are 7 days. We see that she's ovulating. She'll get, maybe a week or short thermal shift, but that's suboptimal. And so what we're able to do there is to hone in and apply the medications appropriately and hopefully get an appropriate time for egg release, which is noted, preceded by the change in mucus. And then we get a good basal body temperature shift. I think the thermal shift is so incredibly helpful when you get women with PCOS and you get all of these mucus patches. It's like, well, which one's real? How do I know this is the one that actually the egg came out? And it can be extraordinarily frustrating. You're like, well, maybe I am, maybe I'm not, maybe I am. And when you get that thermal shift, at least it doesn't guarantee that the egg was released appropriately. It doesn't mean that you had a perfect ovulation event, but it does mean that you have gotten far enough in the process that you're under the effect of progesterone, which is helpful. Progesterone is beneficial for many reasons, even if you didn't want to make a baby, but it gives you more information that at least it's getting further along than you had previously. Oh, yes. So I cannot. So I was trained in, and I'm not certified in this method, but I did training in naprotechnology, which is it's associated with the Creighton model, and that is a mucus-only method. And one of the mainstays for laboratory evaluations is we do what's called a luteal phase progesterone series, and I will check a progesterone level beginning on peak +3, and I check it every other day beginning on peak +3 until the menstrual cycle comes. I cannot tell you how many women will come in and they think they are post-peak, and their progesterone level has not reached the threshold to indicate that. I actually had a lady literally this month who did 7 blood draws thinking that she was post-peak, and she had not post-peak. So I have to send her back to her instructor and say, this is not okay. She's not able to see that. In fact, her estrogen rose up beautifully and then it came back down, and eventually she did get the progesterone, but I think she ended up, rather than with 5 blood draws, something like 13. If she had not had a thermal shift, she would have been able to identify that this mucus patch that she identified as peak wasn't actually the peak. So if you take progesterone in the follicular phase, it can inhibit ovulation. So it's important to either have clear identification of peak and to begin it typically on peak +3, or to begin when you've noticed a thermal shift, which typically corresponds with around peak +2 to peak +3, depending on the method that you're using and what your temperature charting is looking like. But if you do use it out of phase, it can inhibit ovulation from occurring at all. And then how I apply it depends on where the error is. Now, when I do this progesterone series, sometimes I only need to apply it at certain parts of the menstrual cycle. But for many women, they just take it from peak +3 through peak +12 if necessary. Essentially, what you're saying is that if you haven't ovulated by this date that I'm going to start this medication, we're just going to replace the hormone that you would have made and induce what we call a progesterone withdrawal bleed, which should mimic, in a sense, the type of bleeding that you would have, but it wouldn't be identical because, it's estrogen, which is made in the follicular phase and the egg recruitment phase that develops the lining of the uterus. And so while you may have bleeding, it's not going to be the same that you would have in many cases with the normal ovulation event. So that's identical to birth control. So one of the things I kind of struggle with a bit is I'll have, women that will come in and they're trying to avoid contraceptives, or they are trying to conceive, but then in order to regulate their cycles, they are given periodic progesterone, which, it is bioidentical and it is, good in the sense that it's identical to what the ovary is making. If the ovary isn't making it on its own, you're preventing the ovulation event from making it on its own. So it is, can work, it's not meaning like it's meant to be a contraceptive, but in the sense that it will stop ovulation if it hasn't happened. To speak very freely, the data on this is just not robust. There's not a lot of research being done on the international level regarding progesterone levels and basal body temperatures. Most of the publications that are out on this are from the 80s, where it was based on single oral thermometers being taken in the morning. So we need more data on this. I really hope that Tempdrop is able to use their incredible amounts of charts to kind of data mine here and see what's going on. But interestingly, though, it doesn't seem to be the case that how high the temperature gets really correlates with the level of progesterone. And the way that I kind of explain this is when we have women that have ovulated 2 eggs, they are making more progesterone because they have 2 now corpus luteum. So they will have higher levels of progesterone, but we don't seem to see elevated basal body temperatures in those women that have ovulated 2 eggs, nor do we seem to see that in women who have undergone IVF, where they're getting very high numbers of eggs retrieved, 15 or 20, that they're essentially ovulating, and they have sky high corpus, like lots of corpus luteum, lutea, and they don't have that. Furthermore, just an interesting fact is typically, when a woman ovulates and you get a typical peak +7 progesterone level, you'd see it somewhere around 15, 18, 20 on the very high end. And that's enough to raise her basal body temperature. And obviously, if she were to get pregnant, it would stay up. But when a woman is about 38 weeks pregnant, her progesterone's over 100, and her temperature at that point is not 99.9 or 100. So at some point, progesterone stops having the same level of thermogenic effect, if it even is progesterone. There could be some other hormone that we don't even know that is an offset of progesterone, some byproduct of progesterone that's even making the temperature raise, because that's a great question that we haven't understood in science. What if progesterone level is 100? Why don't women walk around with like pathologic fevers level? Not typically, but that's usually because, we do know the complex nature of ovulation, and that any woman who's breastfed or and been charting while she's breastfeeding, you can have wonderful cycles, and then your baby's up all night and has like a nursing session that's just like a newborn, and you're like, wow, that totally messed up my whole cycle. Or you'll get married, or you'll have a big exam, or you get sick, and it can mess up the cycle. So I think if you have something tied to it, some sort of stress event, that's pretty easy to like write off. But if it's one time, I usually like, let's keep an eye on it. And then, but this is the reason why I like charting, is if you see it once, then you identify it, and then you're aware to look for a pattern. So these women will come in earlier versus like 6-7 months down the road, and like, wow, this is really strange. So I think it helps women to clue in on when to pay attention. Let me just say, as a public service announcement, this under awareness of that stress events change our bleeding patterns. This is absolutely true. But this is not true for the postmenopausal woman. So if a woman is 60 years old and she has what she thinks is a period, that is not normal. This is not normal. If a woman has bleeding post-menopause, she's stopped having her period for a year, please do not apply that same logic and say, well, maybe I just had a weird bleeding event. No. This shouldn't be happening anymore, and you should go see your doctor in that circumstance. So I have had some women with luteinized unruptured follicles. That's like a syndrome. They keep having it again and again and again. And I've had one lady in particular, and her charts were absolutely normal. And I needed to do ultrasound series in order to see what was happening because I just hardly could believe it. Then I've had other women who've had luteinized unruptured follicles, and they do have they will have longer luteal phases, although I haven't seen that quite as much. Most of the patients that I see seem to be in the normal range still, actually, which is again one of those reasons why fertility workups or infertility or subfertility workups matters, because you can have what looks like a normal chart and still have an underlying abnormality. I don't see it as much as some other abnormalities, but there are situations where progesterone is being produced before the egg is appropriately released. So in these women, what I usually do is I bring them in, which is cumbersome. Again, I don't know where everybody is living. These women need to come in and get a series of ultrasounds. You need to follow them and see what's happening in these cycles, at least get a baseline ultrasound and see, well, what's going on. And sometimes I'll even do estrogen and progesterone testing. So I'll start with estrogen and progesterone testing, again, every other day to see what's going on. And I can find elevated progesterone levels, which we even see sometimes in IVF cycles where progesterone is being made before the egg is released. It's a known phenomenon in IVF cycles that inhibits ovulation. So it's interesting, it kind of inhibits it from going well, but then it's kind of lingering around. And so it does lengthen it out. But I don't see that very often, but I've seen it a handful of times. Sometimes do see a correlation with, clinically speaking, with cysts, retention of cysts, with bleeding abnormalities. Now, we do use the phrase cyst a lot. I mean, that's a common word. Usually we say it's a follicular cyst or corpus luteum cyst. So we have to describe it in further detail, the size of it, if there's any complexity to it on an ultrasound, and then we typically follow it out. But we do know that having cysts that are large or have not resolved, like essentially an egg that was recruited, a cyst that was developed in a normal cycle seems to have gotten very large, and it doesn't resolve. We just kind of follow it and see if it goes away. Those women do have more episodes of abnormal bleeding, typically. To present that method to their providers, we should be challenged to learn the things that are of interest to our patients. And really what drives our learning is the people that we see. And this is truly why we get up and go to our jobs every day, is that we care for the patients that we are seeing in our offices. So bring your charts. And if they don't seem to show an interest, say, oh, please look at them. and if not, why not? And or do you know anybody that would be interested in looking at it or could help me with it? I just encourage women to keep trying in order to bring it more to the forefront of the medical community and OBGYNs around the world.